Speaking of exercise, when we are exercising immediately, the cardiovascular system has to really quickly increase oxygen and nutrient delivery to working muscles. It also is working on simultaneously removing carbon dioxide, heat, and waste. And there's kind of some key acute exercise responses. Our heart rate goes up because our sympathetic nervous system is stimulated, and therefore we don't have that parasympathetic tone anymore. Our stroke volume is up because we have increased venous return, and we also have increased sympathetic ionotropy. Our cardiac output then goes up because our stroke volume increased and our heart rate increased. So it can increase very greatly in trained athletes. Our systolic blood pressure does increase due to increased cardiac output. And our diastolic blood pressure should stay stable or even decrease slightly because the vasodilation and active muscles can kind of counteract the increased cardiac output. And pulse pressure difference between systolic and diastolic can increase because systolic goes up and diastolic either stays the same or goes down. Our active skeletal muscle gets more blood flow dramatically. This is due to vasodilation locally related to metabolic need. On our heart, our coronary blood flow increases to meet our heart muscle oxygen demand. In the skin, our blood flow will increase to the skin to help heat dissipate for thermoregulation. Our gut, our kidneys don't have any more blood flow. Blood flow will decrease there because we have sympathetic vasoconstriction, and our brain has maintained blood flow via autoregulation. Some mechanisms that increase the heart rate in exercise is this anticipatory response. This can be cortical cortex of our brain stimulation of the hypothalamus, which can prematurely activate the sympathetic nervous system. The sympathetic nervous system then releases norepinephrine, which acts on our beta 1 receptors, which increases the SA node firing rate. And then we have this withdrawal of our vagal or parasympathetic tone. With the rising core temperature, that also will increase our SA nodes, automaticity, and some circulating epinephrine from adrenal medulla, especially at high intensity workouts, can also do increase the rate as well. The mechanisms that lead to increased stroke volume. We have increased venous return back to the heart because of our skeletal and respiratory muscle pumps. This means increased end diastolic volume, which if we have more end diastolic volume, we have more forceful contractions, meaning we have greater stroke volume. Our sympathetic nervous system is activated, so we have sympathetic ionotropy with norepinephrine and epinephrine leading to increased calcium availability, more forceful contractions. And we have faster relaxation because ventricular filling is quicker. This allows for high stroke volumes even at high heart rates. The Fick principle talks about oxygen extraction, and it's really related to, we can see VO2 times cardiac output, so oxygen consumption times cardiac output, times our difference of oxygen between our arterial and our venous spaces. During exercise, we'll see cardiac output and oxygen extraction will increase to meet demand, and tissues will extract more oxygen from each milliliter of blood. Therefore, this difference between the two gets bigger. Over time, an athlete's heart can adapt, and we can see eccentric ventricular hypertrophy for endurance athletes, where we have an increased volume of the chamber, therefore a larger stroke volume at baseline. In concentric ventricular hypertrophy, for resistance or strength exercises, we do have increased wall thickness, which can produce greater force or pressure. In-strength stroke volume at rest is oftentimes what you'll see in a trained athlete versus an untrained athlete. And you also can see a resting bradycardia, lower heart rate of 40 to 60 beats per minute, to maintain normal resting cardiac output despite having larger stroke volumes. Our blood volume will adapt. We'll have increased blood volume, and that will lead to plasma volume expanding, which can have a dilutional effect, lowering hematocrit, but there's better venous return. Our capillary density in skeletal muscle increases, which improves the oxygen delivery to muscle fibers. Our endothelium function improves, so we have more nitric oxide production, therefore we can better vasodilate. We have a reduced resting SVR, which means we have systemic vascular resistance, which means we have lower resistance peripherally, and that reduces the workload of the heart. At rest, we'll have an increase in parasympathetic or vagal tone, which is what causes the exercise bradycardia. We have reduced sympathetic drive at rest and a faster heart rate recovery after exercise, which is why this can be used as a measure of cardiovascular fitness. All of these presentations were used via Claude for formatting, Med Bootcamp, and textbooks such as Medical Physiology, Clinical Anatomy and Physiology by Goiten and Hall and Merib for the resources.